Alrighty, it's 5:33. We will go ahead and get started. Good evening, everyone, and thank you for joining our virtual community lecture brought to you by Providence St. John's Health Center and Providence Little Company of Mary Medical Center. Our focus this evening is on heart health. My name is Emily Enos. I'm the Executive Director of the Heart and Vascular Institute here at St. John's Health Center. Our guest speakers this evening are cardiovascular experts, Dr. Shephal Doshi and Dr. Rishi Kaushal. Before we get started, I wanted to let you know that this is an hour-long presentation. We will have plenty of time for questions, hopefully in the middle, but definitely at the end. This information will be shared in the chat, but please use the Q&A box to type any questions you have. We will do our best to answer each of these questions. Again, trying to do that at the middle of the presentation, but definitely at the end. Please note that we are not able to answer any personal medical questions, but certainly will answer general heart-related questions. If we are unable to answer your question, please feel free to email it to calectures@providence.org. I believe that's already in the chat, and we will get back to you at our earliest opportunity. At Providence St. John's and Providence Little Company of Mary, we provide top-tier advanced treatment for cardiovascular disease. By bringing together expert physicians, experienced nurses, Providence provides complete care to help you maintain a healthy heart. From providing extensive collection of heart disease prevention tips to performing cutting-edge, minimally invasive procedures, our expert teams can help you maintain optimal cardiovascular health. It's not by chance we have Dr. Doshi and Dr. Kaushal presenting this evening, as they've been instrumental in forging the path towards enhanced collaboration between our two ministries, which only enhances the cardiac care we provide in our respective communities. Lastly, we want our attendees to know that the information provided during this program is for educational purposes only. You should always consult your healthcare provider if you have any questions regarding a medical condition or treatment. Now, without further ado, it is my pleasure to introduce Dr. Shephal Doshi. Dr. Shephal Doshi practices cardiac electrophysiology and the management of arrhythmias at Providence St. John's Health Center. He specializes in interventional therapies for arrhythmias, also known as irregular heartbeats, including atrial fibrillation and ventricular tachycardia. Born in Chicago and grown up in Southern California, he attended college at the University of California, Riverside. He received his cardiac electrophysiology training at the Massachusetts General Hospital and served as clinical instructor at Harvard Medical School. Dr. Doshi remains active in leading-edge ablation research involving different forms of ablation energy, which uses heat, cold, or a new energy called pulse field to create tiny scars in the heart to block irregular electrical signals and restore a typical heartbeat. Currently, he is one of the national principal investigators and leading experts in alternative therapies to blood thinners in patients with atrial fibrillation to reduce their risk of stroke. He is one of the most experienced implanters worldwide of the Watchman procedure. With this procedure, patients with atrial fibrillation, a heart rhythm disorder, are able to stop their blood thinners. He remains active in publishing and has co-authored many articles in peer-reviewed cardiac and electrophysiology journals. He travels internationally lecturing and continues to be involved in clinical research and procedures in Europe, South America, and Asia. Additionally, in his role as medical director of the Heart and Vascular Institute at St. John's Health Center, he's been instrumental in bringing the latest advancements and leadership to the multidisciplinary cardiac team. And he's my partner in crime, so I have a special place in my heart for him. Cardiac electrophysiology is also not his only passion, however. He remains an avid lifelong Lakers fan, go Lakers, and loves beach sports, live music, and football. Dr. Doshi, take it away.
Wow, Emily, that was quite an introduction. Back in the days when I was single, I think I would have used that when I went out, but my wife doesn't let me use that kind of terminology. But thank you so much for the introduction. First of all, I want to thank all of you that are on this call. I know it takes a lot at the end of the day, your busy day, to listen to us talk about your health, and we appreciate you being here. I want to thank the team at Providence, and I want to thank my co-partner in crime also, Dr. Rishi Kaushal. When you think of us, you can think of him as a plumber and me as an electrician. And kind of that's kind of the mentality, but our specialties do overlap. And a lot of the symptoms and a lot of the disease states all kind of overlap. So I'm going to try to review some of that with you today. And I'm going to focus on the electrical side and show you some of the new cutting edge therapies that we have available for all of you when you need it. Next slide, please. So if you think about the heart's electrical system, remember the heart is an electrical organ. Without electricity, the heart doesn't know to beat. And we're all born with cells inside our heart that are our own internal clock. So we have our own internal pacemaker that sits in your heart that tells your heart when to beat. It's like that blue dot on top that shoots electricity, which it makes from scratch, and shoots it through the heart. And on the inner lining of the heart is the electrical wiring. On the outer lining of the heart is the plumbing. And the electrical wiring conducts electricity that makes the heart beat in a very organized fashion. And that's kind of the system that we're all kind of born with. But as you can imagine, as you get older, the electric wiring starts to degenerate and starts to short out, and people can have short circuits in their heart, kind of like the kitchen in your light, the light bulb in your kitchen that starts to flicker at a certain point. Sometimes you need to change those light bulbs. And as a field of electricians, we are trained to address these electrical short circuits and the degenerative changes that happen with the heart rhythm. So the question is, what is a heart arrhythmia? Thank you for that next slide. Actually, let's go to that. So heart arrhythmia, and you can go forward here. A heart arrhythmia basically is an electrical abnormality. You have normal heart rhythm, but when the heart starts to have short circuits, it's called an arrhythmia. And there's many kinds of short circuits. And oftentimes, the scary part to some people is that a third of patients who have heart arrhythmias don't feel it. They're unaware of it. Some people can actually feel it. They can feel the fast heartbeats, which we call tachycardia. And so when the term tachycardia is used, it just means your heart's going fast. Is it going fast because you got a letter from the IRS and you're getting nervous and you start secreting adrenaline and your heart starts going fast? Or is it a short circuit in your heart, something abnormal? And one of the things that can also happen when we get older is the heart starts to beat slow, what we call bradycardia. So you see here these terms used often, but that's kind of what they mean. Now, how do we feel when we have heart arrhythmia? And we talked about how a third of the patients don't feel anything. And then, 2/3 of the patients feel something. And these are some of the terminologies that you'll hear. You'll hear the term palpitation. What does that mean? Palpitation just means you're aware of your heartbeat or you feel some sort of fluttering in your heart. And the heart beats 100,000 times a day, every single day. So it's normal every now and then to have a skipped beat. Not everybody feels it. Some people are aware of it. They feel it. They say, oh, my heart's kind of jumping. And we use the term palpitation for that. Some people say my heart is pounding. or I'm aware of my heart, because you're not supposed to be aware of it. It's supposed to do its own thing. And then there's symptoms that kind of occur that are more related to how the heart rhythm can affect your body. So if your heart can beat too slow or too fast, some people feel dizzy or lightheaded because their blood pressure falls. It can be so severe that people feel like fainting. Other people don't feel much in terms of symptoms, except they say, hey, doc, I'm just getting more tired and more short of breath. It's kind of been a gradual thing. The problem is shortness of breath and chest discomfort can be a cause of many things, or can be caused by many things. It can be electrical, it can be plumbing, and we're going to talk about that. And all of them can lead to weakness or fatigue. So there are some specific symptoms that may be related to arrhythmia, other symptoms that are just more related to overall heart disease. Next slide. So how do we diagnose this, right? How do we know? So oftentimes when a patient tells me a story, 90% of that story is I'm going to use to kind of think about what is the most likely thing that's going on. So the history is very important. And now we have tests that can help us understand what the heart is doing. Just because we feel like their heart is pounding, is it pounding just because we're stressed out and we're anxious and it's beating hard? Or is it pounding because you're actually having a short circuit in your heart? And we always start with something non-invasive. That means, it doesn't require any kind of procedure on you, anything that's got risk. So a lot of these things may involve different types of monitors, which we'll talk about. And when those things show some abnormality, sometimes we have to do invasive tests. That is, go in through the vein, go in through the artery, into your heart, and to actually check things out and see what the problem is. Next slide, please. So how do we measure the electrical system? The most common way to measure the electrical system, and you're all familiar with this, you've all heard of an EKG, an electrocardiogram. And it's often the term is used EKG versus ECG in the United States. And the picture you have on the left is very interesting. So this was one of the first ECG machines in the United States at my former institution, Mass General Hospital, that they got, well over 100 years ago. And this technology came from Germany, from some William Einthoven, and this is what it took to get an EKG. Imagine if your doctor said, "Hey, you need to go get an EKG," and you had to go to some lab, put your foot inside a salt water tank and two hands in there, and then change to the other feet. And this is kind of how it started. Now you see on the right, you see something as small as a handheld machine that can get you an EKG, and the technology has taken us a long way. So it's much easier for us to see what's happening to your heart rhythm when you're having symptoms. And now there's other devices that make things easy. So for example, on the left, you'll see a little monitor. It's about the size of a cell phone with a bunch of wires that you put on your chest. And that was kind of the older way of checking. It's called a Holter monitor by John Holter. He was the man who developed it. And this is something you wear on your body for a day, a week, a couple of weeks, because every now and then when you feel something in your chest, at least we're recording it and we can get an EKG. Now, what you see on the right is kind of the more modern way of doing it, and that's where we put a patch or a sticker on your chest, and that's called a patch monitor. And what's cool about this is that you can just get that put on, and you can literally just go and do your thing, take a shower, and keep that on for a week, and it's recording everything. Now, what you see here in this video that's going to play is kind of what people are doing now. They wear monitors. It's called a wearable monitor. This is the famous Apple Watch, but there's many devices like this. And this is a patient of mine who's showing me how she can get her own EKG off the watch. She puts her index finger on the knob and she's holding the watch. And this is when the watch first came out. This patient came to me saying, "Hey, my watch told me I was having my heart was skipping beats." And I said, "Well, how does that work?" And she showed me and took a video of her showing me how it does it. And it does this for about 30 seconds. And then you're going to see the heart's going to tell her, "Hey," the watch is going to tell her, "Hey, you have sinus rhythm. You have normal rhythm." And what's amazing is that tools like this are incredibly accurate when it says it's normal. So when I tell a patient, you have a smartwatch like that, if it's normal, then you can, take that to the bank. When it says it's abnormal, sometimes it's wrong, but these are incredibly accurate things. And so now there's some patients who get devices like this, and I say, "Listen, this happens infrequently. When your heart is pounding, it lasts for 10 minutes. You have the watch on. When it starts doing it, record a signal, and record a tracing of an EKG, and then email that to us." And that's great. And some people can do, but many people have trouble with all this technology, and it's too hard. And the episode happens, once every 4 months. And when it happens, they pass out. So what are we going to do? We've had monitors on, we put the Holter on, we put the patch on, and when they worked, they said I felt fine. But then 2 days after I took it off, I passed out. So now there are these monitors. This is an injectable loop recorder. The monitor is smaller than a AAA battery, and you're going to play that video. You're going to see how we implant this. This little monitor goes just under the skin, and we can inject it under the skin. And we can do this in the office or just in the outpatient part of the hospital. Takes 30 seconds to do. We numb the area with Novocaine, and you don't have to fast. You don't have to stop your meds. You can drive home. That area is numb. We then put a little Novocaine in there, and that's what made it numb. And then we put this small little toner tool, and we just rotate this, and then we're gonna just inject that thing right under the skin. We put a little plunger on the back end, and this whole thing takes like 20 seconds. Now, this thing's got a battery life for 5 years. This thing will link to your smartphone, or you can get a home monitor, and it just records everything 24/7. And if you have an arrhythmia, it sends an alert, either through your phone or through the home monitor to your physician, is saying, "Hey, it's been 4 months, but they finally had this thing happen." Or if you have certain other arrhythmias like atrial fib, which we'll talk about, it can keep a record or a log to see how much you're having. So the technology has really helped us diagnose arrhythmias to a point that now we can offer much more accurate treatment. Okay, let's go to the next slide. So like, for example, this patient was wearing a monitor. They had a patch on, and this patient, they were getting pretty dizzy pretty regularly. So we said, let's not inject a monitor in, let's just put a sticker on their chest. So they're putting this on, and they're wearing this, and this happens. So let me tell you what's going on here. So each one of those spikes is your heart beating. Okay, that's the EKG showing your heart beating. And then what's happening in the middle there is suddenly the heart just stops, right? There's no heartbeats. Their internal pacemaker that they were born with is kind of getting sick. And so having this 3.5 second pause of a flat line, no heart beating. Now, fortunately, most people, they don't die of this when things start like this happen, but they can get very symptomatic. They can get dizzy, they can fall, they can hit their head, they can get injured, they could crash their car, and they could die from it that way, right? So when we see something like this and someone is symptomatic, okay, then what do we do? And in the olden days, we'd say, and and this is still the standard, there's no medicine that can make your heart beat faster when it's too slow. We have medicines that can slow down the heart, but in terms of making things go to, faster, there's very little option for us to do. So, the standard has always been, let's put in a pacemaker. And many people say, gosh, a pacemaker, that's surgery. I don't want to do that. I don't want to go under the knife and I need anesthesia and all this. Well, what you're seeing there are two things in that patient's hand. The blue and white thing is a vitamin capsule. And the thing in front of it is the new kinds of pacemakers. It's a leadless pacemaker. It's just a little bigger than a vitamin capsule. And we can go in from the vein and just kind of in the groin area. And you're going to see a video here of how this works. So imagine this is a catheter that I've gone in from the vein. Now, patients are sedated. They get a little Valium. They're asleep, but they don't need general anesthesia. And can basically advance this into the heart. And then I can push out the pacemaker through this catheter. The pacemaker, the size of a small bullet or a vitamin capsule, is attached to the heart. We tug on it. The numbers look great. We can communicate with it with a remote control so we know what the numbers are. Once we're very happy about how that looks, we cut that little cord or the tether, and then the pacemaker is released. Okay. And so this is kind of the novel types of pacemakers we can put in now. So for some patients, they may not need to even have surgery. This can be done as an outpatient. It takes about 20 to 30 minutes to do the procedure, and then you can go home without any surgical incision or scar. So this is kind of the modern technology of how the pacemaker has evolved. Now, there's still many patients that we put in the standard, the one that goes kind of in your chest, a small incision with wires that go in your heart. But this is kind of some of the new technology that we're able to offer people, which truly leaves them without a scar, but also leaves an internal pacemaker with a battery life, oftentimes of 15 years. And so it's a fantastic option for the right patient as technology evolves. So moving from that, let's talk about what really is the most common arrhythmia or electrical short circuit. That's called atrial fibrillation. This is the most common arrhythmia in practice. What you see on the left is an animation. It's just actually a still picture of the heart, and the upper chamber is the one with all the purple dots. That starts to short circuit. So watch the video and see what happens. So you're seeing the heart is pumping. It's beating normally in the lower chamber. It's kind of beating a little fast, a little irregular. It's not steady. But when you look at the upper chamber, it's all organized chaos. It's completely short-circuiting. And this is really a process of aging. When people are older, it becomes very common. People have high blood pressure, which is common. They can develop this. And when people have sleep apnea, those are common things. And this is a very common arrhythmia. Next slide, please. And so if you think about AFib, remember, this is one of the leading causes of cardiovascular disease worldwide. It's estimated over 10 million people in the US have atrial fibrillation in the next year or two, if not more. And that's 5% of the population. And if you look at those that are over 80, that's almost 15% of the population. So the lifetime risk, if you imagine, of developing AFib in the United States is 1 out of 4. And since it's a disease of aging, if you think about it, 1 out of every 4 people will have AFib at some point. And why is that a big deal? Well, the important thing is that AFib, whether you feel it or don't feel it, it increases your risk of blood clots forming in the heart, which can then go to the brain and cause a stroke. So it's responsible for 25% of all strokes. How does that happen? Look at this video. So when the atrium is short-circuiting, okay, the blood in those two little ear-like things on top called the appendages, it just becomes stagnant like in a pond. It sits there and it turns into a blood clot. Okay, if you're not on a blood thinner and if you didn't know you had AFib, you wouldn't be on one. And then the blood clot gets dislodged. It can work its way up to the brain. And eventually it gets into smaller and smaller branches until it occludes the branch. And then that causes what we call a stroke. And you see that brain tissue will die. And this is very important. This is preventable as long as we can diagnose it and offer you treatment. So what are the treatments of this? Let's look at the next slide. Well, first, it's important to know where the blood clots come from. This is like a cross-section of the upper and lower chamber of the heart. And you'll see in the next, you'll see the arrow. That's how blood flows. It goes from the top chamber to the lower chamber. And the lower chamber is the muscle that pumps it out to the body. But you see a little pouch there with the blue star. This is where the blood clots form. And if the blood clot forms in here, this is a dead end street off a freeway. The blood takes a wrong turn, gets stuck in there, turns into a blood clot, goes to the brain and causes a stroke. And so if you want to see a real picture of it, this is an ultrasound of someone's heart. That's the pouch. And this is a very stressful situation. The blood clot's hanging like an apple off an apple tree, hanging by a little stem, and it will take very little for that thing to break off. And if it does, the odds are it's going to cause a stroke. Next slide. And so when we think about that, we say, well, maybe we can use the symptoms to tell you if you have AFib. The problem is some people, they just feel bad and they know exactly when it starts. They can say at 9:02, my heart went out of rhythm. I was aware of it. It was pounding. It wasn't beating well. And then at 9:12, it went back to normal. That's great. When people have that, we can certainly know what's going on. We can test them for it. Sometimes people just feel more tired. I had a 97-year-old patient say, doc, I've just been feeling tired for the past month. I said, is it because you're 97? And she goes, no, up until a month ago, I was fine. Something is different, and that's someone you can test. But a third of the people don't feel anything at all. And this is the problem. This is the issue that we need to think about. And one of the ways we can reduce your risk of stroke is putting you on the medicines on the left. They're blood thinners, but a lot of patients don't tolerate blood thinners. And so there's a procedure, as you see in the video, that's that pouch where the blood clots form. And what we can do is we can put a cork in it and seal it off. It's like putting a plug to close off the pouch so that the blood doesn't take the wrong exit off the freeway and doesn't form blood clots. This is the Watchman device, which is one of the devices that's most commonly used. And basically, you're going to see that we can put that device and then adjust its position to find the right spot and seal this pouch off. And patients who get this procedure who can't qualify are able to get off blood thinners in a few months' time. And this protects your heart and your brain from stroke just as good as blood thinners do by reducing the risk of stroke by 60 or 70%. Next slide, please. So while that's certainly a great treatment, what about the people who feel bad when they have AFib? Putting a Watchman is great. It can get you off blood thinners, but if it still bothers you, what are you going to do? Well, we still got the old medicines. We can certainly do that. And then there's ablation where I can go in the heart and cauterize the areas that are causing blood clots. And if you look on the left video, this is the old way of doing it. And this is old, meaning many centers still do it like this, but at our two institutions, we have novel technology, which I'll talk about. But the old way requires a lot of skill and has room for error in the sense that, you're moving a catheter while the heart is beating, trying to touch that tissue like you see in that, and then move it from spot to spot to spot without leaving any gaps. So it's like connecting the dots, making sure the dots are touching. And so this is not easy to do. It takes a lot of skill, but there's still going to be some areas where you may miss a spot. So what about the new technology? The new technology, right, is called pulse field ablation. It doesn't burn, it doesn't heat like the old way, but it gives an electric field that doesn't leave gaps, it doesn't leave opening, and it's easy to do. You put the catheter in the heart, you open the catheter up, you advance it into the vein, and you're not burning, you're not cooling, so you're not going to cause any collateral damage, and you deliver this electric field, which is specific for the heart. And it can cause ablation so that none of those cells are going to fire anymore, and your heart will stay in normal rhythm. This tends to work much better and tends to be much safer and is much easier and is much faster. And patients typically have less symptoms than the older way of doing it. And we were some of the first centers in the Western United States to start this pulse field technology. And so between our two hospitals here, this becomes more of our standard way of doing the procedure. Next slide. Here we go. So let's have a pulse field. We talked about it's non-thermal. It doesn't heat or freeze. It's got a large footprint. It can be pretty fast. The lesions are more permanent, which is what we want. We don't need general anesthesia many of the times with this technology. So you can be asleep without having a tube down your throat. And finally, most patients can get same-day discharge, usually minimal symptoms after the procedure. And many patients, we can do them both together. While we're there in the neighborhood, we can do one and the other. And so you say, well, this is great. I fix my AFib, I get off the blood thinners. What does it take? Months and months to schedule? No, we're a fairly efficient hospital. So if a patient needs a procedure, usually in a matter of a few weeks, we can schedule them. And the bigger question for everybody is it covered by Medicare? Medicare in October of last year approved the ability for patients who are over the age of either 65 or 75 who have certain risk factors to get both done at the same time. And many private insurances are also following suit. Next. Okay, and one more. All right. So, what we talked about today is some of the basic symptoms that come from electrical problems. We talked about what happens when your heart gets too slow. We have new technology when it comes to pacemakers. What happens? We have the old stuff too. What happens, when you start having AFib? Well, you got to worry about blood clots and a stroke. You start with a blood thinner. If you can't take it, we have the Watchman. And if you need to fix it, we have ablation, especially the new technology. And the reason why I put this picture up is when you're managing AFib, you can't get too comfortable. You always have to look forward. And that's why some of these monitors make a big difference. They let us know if the procedures worked and how well you're doing. But at the end of the day, we need to work together as clinicians and as patients and healthcare providers because it's all about communication. That's one of the things we're very prideful of here in the Providence Health System. So with that, I'm going to stop as the electrician. We have time for a question if there is, but I want to make sure that Dr. Kaushal has plenty of time to speak.
Thank you, Dr. Doshi. A pleasure learning more about the electrical system of the heart. I think we do probably have we have time for maybe one question, and we have one in the chat. What is the treatment for tachycardia, short-term and long-term?
So great question. Tachycardia just means a rapid heart rate. If the tachycardia is rapid because you haven't paid your taxes when the IRS comes, then you better pay your taxes. That's the treatment for long-term and short-term. But if the tachycardia is an electrical short circuit, then if you're having some symptoms and they're mild, we might just offer you a medication just to take to calm it down as needed. If it starts happening more often, then we can either put you on daily medicine or we can do an ablation for tachycardia also and fix that problem. So we have that as an option depending on how limited you are. All right. Well, thank you. Thank you, everybody. I'd like to hand it off to Dr. Kaushal.
Thank you, Dr. Doshi. We know you need to leave, but we really appreciate you being with us and sharing more information about the electrical system of the heart and all the procedures and advancements. It is now my pleasure to introduce Dr. Rishi Kaushal. Dr. Kaushal attended medical school at UCLA and went on to complete his internship, residency, and fellowship in cardiovascular disease and interventions at Harbor UCLA Medical Center. Multilingual in Spanish, Hindi, and Punjabi, Dr. Kaushal is excited to serve the diverse community residing in his native Los Angeles area. Dr. Kaushal understands the wide-ranging effects that a cardiovascular condition has on a patient and their family, and his motivation and passion for practicing medicine is predicated on providing unparalleled patient care to each individual and their unique situation. He believes strongly in patient education and having each patient play an active role in his or her management of care. He practices interventional cardiology with a focus on treatment of coronary and peripheral artery disease, structural heart disease, and pulmonary embolism. In his role as director of cardiology and the Cardiac Catheterization Laboratory, he has helped to establish Little Company of Mary Medical Center at the forefront of cardiac care by employing the latest advancements, including establishing a rapid response program for the treatment of pulmonary embolism, which is a life-threatening condition. And as I mentioned earlier, Dr. Kaushal and Dr. Doshi have really been instrumental in our collaboration between the two ministries, and it's truly been a pleasure to work with Dr. Kaushal. In his free time, Dr. Kaushal enjoys spending time with his family, music of all varieties, and playing basketball. Dr. Kaushal, handing it over to you.
Thanks so much, Emily. Can you hear me?
Yes, we can hear you.
Okay, great. Thanks for the introduction. Dr. Doshi is always a tough act to follow. I really did a beautiful job on a very complex subject. So we're going to switch gears here a little bit and talk about some other kind of general forms of heart disease that Dr. Doshi didn't mention. As he did mention, I'm kind of the plumber of the system, and we're going to talk about some specific circulatory or plumbing issues that can affect the heart and what we can do about that nowadays. So the term heart disease itself is kind of a general broad term, and that's basically used to define various conditions affecting the heart and blood vessels. The most common form of heart disease is going to be coronary disease, and that's essentially blocked heart arteries where your heart's not receiving adequate blood flow, and that usually will manifest with symptoms such as chest pain or a heart attack. Heart failure is another form of heart disease. The heart essentially is a pump. It's a large muscle. And through various mechanisms, coronary disease being the most common, that muscle can become weakened and inadequate to sustain measures of life. And that can often manifest with shortness of breath, swelling, and often unanticipated weight gain. Arrhythmias and slow electrical circuitry within the heart, Dr. Doshi covered. Also, an important form of heart disease is valvular disease. We're going to talk about a specific form a little later in the evening with aortic stenosis. The heart, as you may know, has 4 heart valves. All heart valves are subject to wear and tear that can occur throughout your life. And some people are born with congenital issues that can lead to either insufficiency or a leaky valve or accelerate the process of making a valve restricted, so inadequate to keep up with the demands of your life. So why does it matter? Obviously, heart disease is really important, despite the strides that we made in reducing the overall prevalence or numbers in the United States. It still is the #1 cause of death in the world, including the US. 1 in 3 adults has some form of heart disease, and really, really important, many forms are preventable and treatable. So oftentimes I have a conversation with my patients, especially the younger patients, and they're often overwhelmed and really downtrodden that they have this form of heart disease. And I really try to empower them with the information to say, look, this is controllable. It's treatable. You have the power to really affect your prognosis and your lifespan and your quality of life. So this is certainly not a death sentence. And I think that's hopefully one of the take-home points of today's talk. And in the time that it took me to go through the slide, approximately 40 seconds, someone in the US had a heart attack. So literally every 40 seconds, someone has a heart attack in this country. And that's obviously a big problem. Signs and symptoms, Dr. Doshi went over this briefly. In general, there's going to be a lot of overlap, like you mentioned, regardless of what form of heart disease that you have. And chest pain and discomfort is going to be one of those symptoms. Shortness of breath, specifically exercise-induced or physical activity-induced shortness of breath, can be a telltale sign of cardiac disease. Fatigue with activity, palpitations, which you mentioned, swelling in the ankles. Most often I'll say swelling in the ankles has other non-sinister causes, so to speak, but it's important to bring these symptoms to your healthcare provider so he or she can kind of parse through the details, and lightheadedness or fainting. Importantly, let's talk about what are the signs of a heart attack. So there's kind of classic symptoms or typical symptoms and then atypical symptoms. Many patients won't have these classic symptoms, but let's start with the classic symptoms. That's usually going to include chest discomfort. It can be a pressure, a heaviness, a tightness. Kind of the classic description is an elephant sitting on my chest. Not all the time, so we have to cast a wide net when we're listening to our patients. But oftentimes that symptom will radiate to the jaw, the neck. I had a patient with persistent tooth pain both sides of his jaw when he was exercising, and he misinterpreted that as a dental infection, and in fact, it was chest pain from his heart. Other associated symptoms, feeling very sweaty or diaphoretic, having nausea or vomiting can be a symptom of a heart attack as well. Very, very important to recognize that women will not often have the same symptoms as men, and they will often not manifest chest pain as their primary symptom of coronary disease. So often that can be dizziness, fatigue, stomach pain, nausea. If this is happening consistently when you're exercising, then the suspicion is you may have a severe blockage. If this symptom or these symptoms start suddenly at rest, that's more concerning for a heart attack, and that should prompt a 911 call right away. What we say in cardiology is muscle or time is muscle. So the quicker you call, the quicker you seek medical care, the more we can protect your heart and the less injury you can prevent. And injury to the heart in terms of a heart attack is irreversible. So obviously you want to minimize the time that heart muscle is injured. So let's switch gears and talk about risk factors. So again, extremely important to understand what your specific risk factors are and what you can do about them. This is going to involve a partnership with your healthcare provider. You can't determine this on your own. Okay, you need labs, you need to get your blood pressures checked. So seeking regular medical care is step 1. We're going to boil this down into modifiable versus non-modifiable risk factors. Modifiable are those that you can control. High blood pressure, typically greater than 130/80, is regarded as high blood pressure. A simple difference of more than 20 points for that top number, your systolic, above a normal blood pressure, which is 115/75. So a 20-point increase will double your cardiovascular risk. the presence of diabetes will increase your cardiovascular risk by 2 to 4-fold. Smoking is one of the worst things we can do, and it basically incites this inflammatory cascade within the brain and the heart vessels, which often is irreversible, can often lead to heart attack and plaque buildup. Obesity, elevated total and LDL cholesterol. We're going to talk about more specific forms of cholesterol a little later, and a low HDL. So HDL is your good cholesterol. You want that number to be high. Exercise, avoiding refined sugars can achieve that. But when your HDL is low, oftentimes it's genetic, and that can be a risk factor as well. And being physically inactive is a known risk factor. So what are the risk factors that we can't control? Obviously, your age, your gender, being male, excuse me, increases your risk of cardiovascular disease, and understanding your family history is really important. So a first-degree male less than 55 or a first-degree female in your family less than 65, if they have had heart attack or stents or bypass surgery, that can potentially increase your risk. Currently, this is considered a non-modifiable or uncontrollable risk factor. This is called lipoprotein A. Probably most of you have heard about this. It's a specific form of cholesterol that can predict kind of the aggressiveness or behavior of a person's plaque. And this is really getting a lot of important highlighting within the press, and it dramatically can help us to refine a person's risk factors. So a patient can have a perfectly normal LDL, but a very elevated LPA, and that's important for us to know. So whether you have risk factors or not, it's important to be on obviously the positive side. You want to aim on the side of prevention so you're not in trouble. When you have heart disease, these factors are extremely important as well, because again, you still can control it. So in terms of diet, and this is, I feel like maybe 40% of my conversations in the office revolve around diet, and there's so much information out there, so many fad diets. It's really hard to know what to do sometimes. And so my advice always is to pick one, study one, talk to your healthcare provider, and stick with it. In general, the diets that I recommend, and these are going to be validated mostly by the cardiology community, in terms of the research and long-term outcomes, are going to be the DASH diet, plant protein based diet, and the Mediterranean diet. And this is where we emphasize the intake of vegetables, fruits, nuts, whole grains, lean protein, and fish. You really want to minimize the intake of trans fats, and these are partially hydrogenated oils, red meat, processed food in general, and importantly, refined carbohydrates and sweetened beverages. So any processed sugar, refined sugar, baked goods, obviously any sodas, even diet sodas, you really want to avoid. They have a very pro-inflammatory effect. Inflammation is kind of the root of all evil, as we come to know, including plaque buildup and atherosclerotic heart disease, which again can cause coronary disease. We know that alcohol and excess alcohol intake, which is defined as greater than 5 drinks a week, can significantly impact your cardiovascular risk. So you want to limit alcohol intake to less than 1 drink a day, and exercise, exercise, exercise. If you're not using it, you're going to lose it. And this is, my patients who are on this call probably hear me say that all the time. If you're not using your muscles, they're going to waste away. You need to take advantage of the opportunity. If you have the ability to exercise, this is free and the cheapest way to get yourself out of trouble. What we recommend is 150 minutes of moderate exercise or 75 minutes of vigorous activity per week. Moderate is going to be a brisk walk, doubles tennis, biking, like a slow to moderate pace bike. Vigorous activity is going to be swimming laps, running or jogging, biking at a higher speed defined as greater than 10 miles per hour, and singles tennis, just to give you a little idea. This slide I love because there's so much truth in it. I'm guilty of doing this myself, but I include this because it doesn't take, a 5-year commitment to join a gym to make lifestyle changes that are going to be positive for you. It's really simple decisions like taking the stairs at work or wherever you are, parking a little further away when you're at the store. And those are the choices that literally will put years on your life. Stopping smoking, we talked about managing your stress levels. Good luck with that. I haven't figured that one out myself yet, but that's very important. And obviously controlling these risk factors, controlling your blood pressure, cholesterol, blood sugar through, again, that partnership with your primary care physician or provider. And I highly recommend, if you're between 40 and 75, with your healthcare provider, calculate your specific 10-year cardiovascular risk. That is literally your risk over the next 10 years of developing a cardiovascular event, including a heart attack or stroke. And that really helps us to personalize your individual healthcare plan by understanding your risk, and that can open up a dialogue potentially for statins or other therapies if your numbers aren't where they should be. Statins get a lot of bad press, but the cardiology community, including myself, in general agree it's still one of the most important primary forms of prevention that we can apply for our patients. I included some references here. We're not going to have time to go over this, but just a little bit more definition in terms of what these diets and what physical activity is recommended. So let's talk about prevention. What's new in prevention? There's a lot. Okay, but I hopefully boiled it down to what I feel the audience is kind of most important to know. Advanced lipid testing, extremely important, very available to us now. And we know that a person with a normal cholesterol value, normal LDL, for example, still can carry elevated risk. So a standard lipid panel is not going to tell the entire story. What an advanced lipid test does is we start to calculate particle sizing, densities. We start to measure lipoprotein A, apolipoprotein B. These are important subcategories that tell more of a complete picture that's going to help personalize your risk. Okay, and oftentimes, again, I'll have patients with normal LDL levels, but other markers which convey an elevated risk, and that changes our treatment strategy for that patient. Coronary artery calcium score, we're going to talk about this a little bit more in detail. This has really revolutionized our ability to detect plaque that is already developed, and again, hone in on a specific patient's risk and how aggressive to be. GLP-1 agonist, this is kind of the talk of the town. I'm sure everyone's heard of these. This is your semaglutide or Ozempic, your Wegovy, your Mounjaro. Traditionally began as an injectable medication used to treat diabetes. What we found in large-scale randomized trials is that these medications really have been game changers in reducing cardiometabolic risk. They have positive impacts on blood pressure, your lipid profile, in addition to weight management. And again, these large-scale studies have shown very significant improvements in a patient's cardiovascular death rate, specifically in these three categories. So patients with diabetes with known heart disease, patients with diabetes without known heart disease, but with risk factors, and even in the absence of diabetes, if you're obese or overweight being a BMI over 27, and if you have traditional cardiovascular risk factors. So I urge a conversation with your primary docs to see if this is right for you. So we're going to switch gears here a little bit and talk about two specific forms of heart disease, which are very common and affect the plumbing or the circulation side of things. So coronary disease, I already mentioned, is the most common manifestation of heart disease. Essentially, it's plaque buildup with mostly cholesterol that occurs within the coronary arteries. Your heart requires its own set of circulation, and these are the coronary arteries. As Dr. Doshi mentioned, these arteries sit on the outside of the heart, and they're small little penetrating arteries that go into the muscle to help supply that heart muscle with blood. When you get enough of a buildup, your heart muscle then is going to be devoid of oxygen. And again, there's two manifestations I mentioned at the beginning of the talk. When you're physically exerting yourself, if there's a severe narrowing, that's usually when patients are going to manifest exertional or physical activity-induced symptoms such as chest pain or shortness of breath. If it's an acute or fresh blockage, so sometimes you can have a 60% narrowing, undergoes inflammation, you get what's called plaque rupture. That 60% narrowing can go to 100% in a matter of minutes, and that's what causes a heart attack. That's going to cause those acute symptoms, which can again lead to a heart attack. Angina is the term that we use for chest pain and sudden death. So coronary disease is the most common cause of sudden death. Typically in patients with large heart attacks are at risk for this. And congestive heart failure, again, your heart's a pump. If it's devoid of oxygen for an extended period of time, you're going to get irreversible injury, and that pump's not going to work as well. Unfortunately, coronary disease often is silent until it's advanced. So again, understanding your risk factors and the technologies available to make this diagnosis is critical. So let's move into diagnosis and treatment of coronary disease. The coronary calcium score, again, in the last 10 years, really has changed the game in the ways that we recognize plaque buildup in patients. It's a quick, cheap, and very easy test to get. It takes about 60 seconds. It's a very quick CT scan. And what we do is we measure the calcified plaque that a patient has already built up. Importantly, it's not going to measure overall plaque. So there's soft plaque and hard plaque. This is only looking at hard plaque. Soft plaque is usually how it begins. Once it's there for a while, it gets matured into calcified or hard plaque, and that's what we're measuring. Once we quantify it, we can give you a score, which then gives us more precise risk estimates and tells us what you need to do to get yourself treated better. A score greater than 400 significantly increases your 5-year risk of having a cardiovascular event. And sometimes we have patients in the thousands. And again, we approach that patient very differently. And so I use this in my practice very often for patients who are kind of on the borderline of needing a statin or not. This is often a tiebreaker. For patients with some borderline risk factors, this is critical, gives us a lot of information. Coronary CT angiography is a little bit more of a sophisticated CT scan. We use contrast or dye, so that lights up the inside of the arteries, and we do 3D reconstructions on the arteries that give us beautiful images like this. This is going to give us a more comprehensive assessment both of soft plaque and hard plaque and an estimate of how much narrowing that's going to cause. So this has also been kind of a game changer in terms of identifying plaque in patients who have risk factors or extensive family history or symptoms that we can't explain. Stress testing is still very widely used in the cardiology office. This is an indirect way to measure blood flow. Oftentimes, a patient's going to get on a treadmill and exercise. Occasionally, if the patient can't exercise, we can do chemical forms of stress, and that's very important. If any of the above tests, and this is certainly not an inclusive list, but if any of the tests above are positive, or if a patient comes in with an acute heart attack, that's going to lead to a procedure called a coronary angiogram. So this is a minimally invasive procedure. It's a direct way to look at the heart arteries to see if there's any blockage. The majority of cases we can actually now do through the wrist or the radial artery. And this procedure involves a small plastic tube called a catheter. We get access into the artery with a small needle. Occasionally, we still have to go through the femoral artery if there's a corkscrew or if we can't get to where we need to through the radial artery. Once we get that plastic tube to the heart arteries, we then inject a dye material, and this is an example of an angiogram. This patient happens to have normal coronary arteries. We move an X-ray tube around the patient as we're obtaining these pictures to get a more comprehensive assessment. And this is the way that we definitively diagnose if a patient has coronary disease and how extensive their blockages are. Based on the degree of coronary disease, the typical way that we're going to treat these patients is with coronary artery stenting. Not every patient is going to be a candidate for stenting based on the location of disease and how much disease they have. Coronary artery bypass grafting or surgery still plays a role, but many patients are candidates for stenting. A stent is a small metal tube. It's a permanent scaffold that stays in your artery. Importantly, we're not taking away plaque. We're displacing plaque to create more of a channel for blood flow to occur properly. In this image here in the lower left, this is an example of a 99% narrowing. You can see kind of this cutout. So the dye material is having a hard time going past that. And this is what it looks like after a stent is placed. This is most commonly an outpatient procedure, typically for patients who have a radial approach. Once the procedure is done, you can immediately get up, walk around, as opposed to the old days where we were using sandbags and other things to prevent bleeding from the groin. And this is an example of a coronary stent. Again, a very, very small metal mesh, not going to set off any detectors at the airport. The size range is about 2 to 5 millimeters in diameter, which approximates the size of a patient's coronary artery. This is an example of a heart attack. So this is 100% blocked artery. And this is basically what we do. In fact, I'm on call tonight for heart attacks. So, if a patient comes in tonight, this is usually what we see. And after a little bit of work, we get the artery open, place a stent. You cannot see the stent here, but you can see that blood flow is reestablished. And this has really been revolutionary in terms of the treatment of patients with heart disease and has saved countless lives. This is a quick example of a coronary angiogram. We'll let this video play. This is the patient's wrist. We get access again with a small needle. We insert that metal tube or plastic tube rather Once we find a significant narrowing, a small metallic guide wire is placed across that. This is a stent. The stent is collapsed on the catheter. Underneath the stent is a balloon. Once we get that stent to the area that's narrowed, we inflate that balloon, quickly deflate the balloon, and left in its place is this nice metal scaffold, which again is the stent. All stents nowadays are by default coated with a drug that prevents inflammation in scar tissue. So the stents stay open longer. And within 3 months, as you can see, the stent gets incorporated into the vessel and patients can come off certain blood thinners. Once we're done with the procedure, which typically can last 45 to 60 minutes, we remove that tube, put a small wristband on to prevent bleeding, and the patient can go home in several hours. Advances in coronary disease really are numerous. I just included a few examples. The one in the top left here is called OCT, or optical coherence tomography. It's a way to visualize the artery from inside the artery. So when we're doing an angiogram, we're looking from the outside. But we have imaging to look at the inside, which gives us plaque composition, lots of details, which is very vital to treat the patient appropriately, and sizing of the stent. And so you can see these beautiful pictures, and this is what we use in the cath lab almost on a daily basis. Coronary calcium is kind of a plumber's worst nightmare. It's trying to unclog a drain that has a bunch of rocks in it, essentially. And so technologies advance really beautifully where we have small, minimally invasive catheters which send out radio frequency signals. This is called intravascular lithotripsy. The idea was obtained from pulverizing kidney stones. This is the same technology that's used. It basically pulverizes and breaks up that calcium without causing it to come loose so that we can fully deploy and implant a stent and get proper results. This is a different form. This is called rotational atherectomy, where we get a diamond-coated steel burr, rotate that at about 170,000 RPMs in the artery, and surprisingly, it's extremely safe, only abrades the calcium and not the native vessel to allow us to put a stent in safely. And nowadays, we also have the benefit of being able to use heart pumps, which can be life-saving in patients with failing ventricles or failing hearts, patients coming in with cardiac arrest or massive heart attacks. Think of this as a big suction straw. It pulls blood out of the ventricle, pumps it to the rest of the circulation, and this literally can fit inside the palm of your hand. This goes through the groin artery, and this can sit inside your heart for 5 to 7 days. And this, again, has been life-saving for many, many patients. We're going to switch gears here a little bit. I'm running out of time, so we're going to run through this fairly quickly. But we're going to talk a little bit about valvular heart disease, specifically aortic stenosis. This is a very common form of heart disease, mostly affects patients who are older, above the age of 70. And this refers to a narrowing of the aortic valve. This is an example of the aortic valve. It's the main gateway. Once the heart muscle squeezes, the aortic valve opens to allow that blood flow to be ejected. Through various different mechanisms, this valve can become calcified, restricted, where you don't have a healthy opening and you get limited amount of blood flow. This can lead to congestive heart failure, symptoms of exertional fatigue, shortness of breath, fainting, and it can be fatal if left untreated. The natural course of this is that it will get worse over time. Seeking regular medical care is very important because oftentimes this is diagnosed when your doctor takes a listen to your heart and they'll hear a murmur. That's going to prompt an ultrasound of the heart where we can easily make the diagnosis. 10 years ago, the only way to get this treated was open heart surgery. Fortunately, a revolutionary technology called TAVR, transcatheter aortic valve replacement, has been utilized to minimally invasively correct this problem without surgically removing the valve. We actually implant this new valve in place of that valve. Benefits compared to surgery, shorter recovery time. We can do this procedure in less than 60 minutes. Our patient this morning was wide awake. Lots of local numbing medicine in the groin where we put the catheter, minimal sedation, and comparable valve durability when we compare this to surgery. Oftentimes, patients were not candidates because they were too sick for open heart surgery. And so this has really opened the window to offer those patients treatment. It's had such astounding success that this is now indicated for high, intermediate, and low risk patients. The next step is going to be indication for patients even without symptoms because we know those patients do poorly. And this importantly has opened the door to even more minimally invasive options for other forms of valve disease that we use every day in the cath lab now. Real quick video on how we perform TAVR. This is quick. I had to speed it up a little bit. This is our catheter going through the groin. And this catheter basically has the valve that's collapsed Very similar to stent technology, there's a balloon that underlies this. We don't remove the existing valve. We cross the valve, inflate that balloon, and what you have left is this nice new functioning valve. And so it's just a beautiful technology, really has opened the possibility of treating so many more patients in a very short amount of time. And that's what it looks like on the inside. And at Little Company Mary in St. John's, we've been performing TAVR for now close to about 6 to 7 years. We've had tremendous success in this, and really the future's limitless for these minimally invasive procedures. Take-home points: heart disease, again, preventable, treatable, very prevalent, but you have the power to do something about this. Do not consider yourself without the ability to do something. Awareness of symptoms and risk factors is critical. Lifestyle changes and medical advancements we talked about tonight are really game-changing and advance the treatment options for many patients. And again, I can't emphasize this enough. A partnership with your doctor is so critical to really target this and prevent this. And I'll close with this. I love this slide because we're all guilty of it, myself included. We all have busy lives, and we often make excuses for not having time to exercise or putting the work in, but certainly consider the alternative. Thank you for your time. I think we're going to take questions now.
Thank you, Dr. Kaushal. I think we're all going to go for a walk and do some meditation now. Before we do begin Q&A with Dr. Kaushal, we do have a few questions for you, our participants. So please answer. There should be a poll that's coming up on your screen. So if you could give us some honest feedback, we do greatly appreciate it. And as you are doing that, I will go through some of the questions in the chat for you, Dr. Kaushal.
Thank you.
There is one regarding the coronary calcium score. Since this test scans 4 arteries, does it indicate a much greater risk if the score is coming from all from one artery? Would that indicate a need for more testing rather than looking at overall score?
Yeah, really good question. And so, the score that you get, as you know, is quantitative, gives us a total score, but then we can break it down specifically to what artery has what degree of calcium. And, when we do see very high scores, greater than 200 in one particular artery or one particular location within the artery, remember, it can be kind of spread out within a specific artery. But if it's in a focal point, specifically, that does cause a little bit more concern that there may be more blockage in that specific area. Typically, I'll follow that with a stress test if a patient already has not had one. Based on that, the calcium score, we can also follow that up with a coronary CT angiogram. Sometimes very high calcium scores preclude the ability to get a coronary CT because oftentimes a lot of calcium is going to cause shadow artifact on the coronary CT, and we may not be able to see what we need to.
And I have a question. So if a patient has a heart attack or they have open heart surgery, or they have some type of cardiac event, is there a safe way for them to get back into exercising? Is there any type of, I've heard of cardiac rehab. Is there any type of controlled system where they can get back into it? Because apparently it's very important based on your presentation, right?
Absolutely. Thanks for mentioning that. That's a really good question. And like you mentioned, cardiac rehabilitation is research proven to help safely kind of reintegrate back a patient, if you will, to exercise, whether you were doing it before the event or not. But basically what cardiac rehab entails is supervised exercise, where cardiac nurses are monitoring your blood pressure, your vital signs, even an EKG. And both St. John's and Little Company both have excellent facilities. We have our own individual cardiac rehabilitation facilities. And most patients come back wanting more. So your insurance is going to improve typically 36 sessions after a cardiac event. And most patients are really upset that they may not be able to continue after that. So that tells you really how much they enjoy it. And what research has shown is that patients actually live longer, feel better, and stay out of the hospital more once you complete cardiac rehab. So it's an absolute prescription for patients with congestive heart failure, with valvular heart disease, with heart attacks, and most patients who have undergone a certain type of heart procedure.
Awesome. And I think we have time for maybe one more. We have one going back to ablation. What is the risk of developing endocarditis after an ablation?
The risk is really low, so it is a good question. These are sterile procedures, as all cardiac procedures are. And the incisions are so small that introducing bacteria from a skin incision is going to be very low. Theoretically, creating some scar tissue can be a nidus or source of infection for future bacterial seeding, but I don't think that that's a real concern. I think the numbers are probably much less than 1% in terms of endocarditis.
And based on if I'm listening to your lecture or to Dr. Doshi's, there's a lot of symptoms, and maybe I have some of those symptoms, or I know a family member who does. How would I know if I need to see an interventional cardiologist, or do I go through my primary care? What would be next steps for me?
Yeah, so that kind of the benefit of subspecializing within cardiology is that you do your general cardiology fellowship first. So whether it's an electrophysiologist, interventional cardiologist, we all have obviously general cardiology training, so we can parse out kind of which specialists you may need to see. I often get referred patients with chest pain, and we get to the bottom of it. It tends to be an arrhythmia, or if it's an arrhythmia, I'll send them to Dr. Doshi or electrophysiologist. So don't get too hung up on who exactly you need to see. It's always a good idea to touch base with your primary care provider, but if your insurance allows you the ability to be seen by a cardiologist without a referral, then you can see any former cardiologist.
Well, thank you, Dr. Kaushal. And with that, we will wrap up. Thank you all for attending this lecture and for your excellent questions. Big thanks again to Dr. Kaushal and Dr. Doshi for taking the time to provide us all this amazing information. Again, I think we're all going to go for walks or climb the stairs tomorrow, right? Go for meditation tonight, at least. We will be sending a recording of this presentation to all the attendees. It's also going to be posted on our Facebook pages and YouTube channel, which you can access by typing Providence into the search bar. As mentioned earlier, Providence St. John's Health Center and Providence Little Company of Mary Medical Center San Pedro and Torrance have you covered, as you can see from this map. To find a physician or to schedule an appointment, please call our Patient Engagement Center at 1-855-415-8191 or visit us at providence.org and click on Find a Doctor tab in the navigation bar. We look forward to caring for you and your loved ones in your cardiovascular health and beyond. We hope that we inspired you to take little steps today to prioritize your cardiovascular health, which will make big impacts for the future. Thank you again and have a great rest of your evening.
Thank you, Emily. Thank you to the audience.